All right, welcome back to the second part of the disorders lecture. So we finished up by talking about some of the causes of anxiety disorders, and let's jump into eating disorders now. So eating disorders are, just like they sound, disorders related to eating habits, maladaptive, persistent. So, that one time when you just kind of mindlessly ate a whole pizza to yourself, that's not exactly indicative of an eating disorder. But if that's something you do, you know, twice a week, three times a week, if it's persistent, if it happens regularly, then it's maybe looking like a possible eating disorder at that point. So let's briefly talk about the biopsychosocial model with eating disorders. Just like most things, there's a contribution from all three sides of this triangle. On the biological side of things, there's definitely a genetic component to eating disorders. Roughly 50% of children of parents with eating disorders will go on to develop their own eating disorders. So, about half the kids that have parents with eating disorders will develop an eating disorder. That's definitely indicative of some sort of genetic component. The psychological side of things, eating disorders are often comorbid, meaning an eating disorder is usually one of two or three or four different disorders that exist simultaneously. This is usually, or not usually, but sometimes it is the result of trauma. It could be verbal abuse, emotional abuse, and we also have the operational um, or um, the uh, operational, sorry, reinforced behavior. So, yeah, operant conditioning. That's the word I was looking for. We have the operant conditioning principles of reinforced behavior. So, that could be something like if you're looking thin, people compliment you. If you gain weight, people don't compliment you. They might even insult you. That's socially reinforced behavior. And then we have the social side of the triangle, societal expectations, peer encouragement. Those can be two very powerful factors on our eating habits. So let's start by talking about anorexia. The full clinical term is anorexia nervosa. This is a persistent restriction of energy intake. Some of the symptoms are usually significantly low body weight. There is an intense fear of gaining weight, and there's usually a pretty severe disturbance in self body image. So even though they might be extremely thin, they think of themselves as fat, or they're terrified that they could gain any fat at all. These are some of the classic symptoms of anorexia. Okay. This is the most deadly disorder in adolescence. It is a really nasty disorder. It sticks around. It's really hard to get rid of completely. It's something that you try to manage eventually because it's actually very difficult to eradicate completely. It is extremely deadly. It's definitely not good for your body to have extremely low caloric intake. And if that's something you're doing on a persistent basis, then there's going to be some pretty long-term health effects. This is usually a bimodal age distribution, meaning that there's two different peaks. If you were to graph out when people usually suffer from anorexia, there's going to be a lot of teenagers that suffer from anorexia. And then later on, like in your early 30s, late 20s, there's going to be another kind of peak, another uh, high prevalence time for anorexia. And in between those two peaks, there's not a lull, but something resembling a lull. So this correlates with typical start and end, the average start and the average end of our peak fertility years. So the times when we are most fertile, most likely, at least biologically, to produce offspring. So there might be some relationship there. These eating disorders pop up when we're at least biologically tuned or programmed to start making children. After anorexia, we're going to talk about bulimia. Again, the clinical term here is bulimia nervosa. I have a short video there linked on the course website. This is a video looking at or discussing the prevalence of eating disorders with athletes, and they have a short interview with a young woman who suffered from an eating disorder but was eventually able to get rid of it. So what is bulimia? Well, this is where there's usually recurrent episodes of binge eating. Binge eating is usually defined as eating an amount of food that is abnormally large, and during that binge eating period, the participant or the patient feels a lack of control. After the binge eating, there is some sort of compensatory behavior. That compensatory behavior is meant to sort of make up for all the calories that were just ingested. So getting rid of those calories could be through vomiting, could be through the use of laxatives, or the person could go into a fasting period, or they could engage in some extremely rigorous exercise for extended periods of time. So binging and purging, there's this binging period where a lot of calories are consumed, and then this compensatory period where the calories are either purged from the body or used somehow. In order to meet the clinical definition of bulimia, this has to occur at least once per week for 3 months. So that would be 12 weeks. So once per week for 12 weeks, and that's the minimum. Again, if a lot of people, when the holidays come around, they engage in a lot of overeating, maybe even some binge eating episodes. But then afterwards, people might, they try to follow their New Year's resolutions of working out every day or something like that. If you do that once a year, then, that's not really our definition of bulimia here. All right, and we're going to finish up this lecture by talking about sexual dysfunctions. So, the best data that we have is that roughly 43% of women and roughly 31% of men have experienced some form of sexual dysfunction. Now, this is really hard to get good data on for an obvious reason. This is, really personal information. This is hard information to get out of someone unless you've established rapport or some sort of trust. This isn't exactly information that people are just willing to give out all willy-nilly. So these are really our best guesses. The numbers might be much higher, but people who suffer from them are just not willing to admit it, which is totally understandable. Some of those sexual dysfunctions could be things like um, erectile dysfunction in men, or there's certain orgasm disorders in women. There's ejaculation delaying disorders in men. So the term sexual dysfunction can mean many, many different things. But the one that we're going to talk about is paraphilias. Uh, this is another, or it's also called fetishisms. And this is, again, a distinction we need to make between how a word is used sort of in the general culture, the general population, and how it's used in a clinical setting. The term fetish in the general population sometimes means, you just have a fascination, or that's maybe your hobby, to engage in a certain act or to use certain things when engaging in sexual behavior. But in a clinical setting, the term fetishism is a mental disorder. It's a sexual dysfunction. So what is it? So fetishism is when an inanimate object is needed for sexual arousal or to have an orgasm. And oftentimes what we see is that there is harm caused to the partner, the sexual partner, or the self of the person who has the fetish by using the fetish object. Um, so there's some object that is needed for this person to get aroused in the first place or to reach climax, and the use of that object is harmful. It's maladaptive. That is the clinical definition of a fetish or a fetishism. A little bit different than how it's used in the general population. For this, again, to meet the clinical definition of a sexual dysfunction, the behavior has to be present for 6 months or longer. So, for half a year, that's a long time. And this can occur, and there are case studies of this occurring with a specific body part. Feet are a great example. Um, Someone may need to have feet present or constantly touching feet in order to reach climax or have sexual arousal in the first place. All right, I believe that is the last slide. Yep, it sure is. All right, that is it for the disorders. I've got a couple more disorders to talk about in the next lecture that I've kind of grouped in with the therapy lecture. So thanks for listening and stay tuned for the next one.